So welcome to the 2019 Predoctoral Education Workshop. Thank you all for taking the time to come down on a Saturday morning. It's very much appreciated. We know we had a lot of different opportunities to be at different seminars this morning, but we really appreciate having you here and hearing your thoughts and opinions and your experiences. So this morning's lecture, or workshop, I should say, is really comprised of three different sections. The first part, I'm going to take a few minutes real quick and share the results of the survey that most people completed, which was sent out about a month and a half ago. Can you still hear me if I put this down here? Yes. It's all good? Okay. So we'll take a little bit of time. And the idea is just for each of you to be able to relate as to what's going on out there. Because when we're back at our own institutions, sometimes it feels like we're the only ones going through that battle, through those experiences. But this way, it kind of allows everyone to hear what the trends are. Then we're going to have two speakers sharing their experiences with us. And the way we've selected this morning is we're going to have a speaker from a program that has a postdoc and a speaker from a program that does not have a postdoc perio program. So hopefully one of them will relate to pretty much everyone, at least in the room, depending what institution, what setup you have at your institution. Then the fun part starts. We're going to do a breakout session, and I'm going to go over some of the details and instructions of how we're going to do this at that point, where we really want everyone to get involved and share your experiences so then we can summarize everything and share that with the group by hopefully 11:30. We're trying to stay on time when we finish. So without further ado, I'd like to start with, let's get this going, with the workshop, with the survey. We had 48 institutions reply back, and that was a pretty good number. And everyone, the numbers I'm going to be looking at is pretty much divided amongst those 48. So we're pretty much 50-50 split between programs that are discipline-based versus programs that are general dentistry-based. Regarding who teaches periodontics in the different institutions, the majority of programs, there's almost 100% periodontist teaching. However, the interesting part was about 50% of the programs have either residents or hygienists also helping out. And there's about 25% of programs that have general dentists helping out. So I think that's an opportunity when we're looking at the workshop later this morning to see how we can help address to make sure they are also presenting and explaining and understanding the same concepts of perio as the periodontist in the educational or the perio residents or the hygienist in the program are doing to help maximize the benefits of that. Regarding the implementation of the classification in the previous year, so I know we've started a new academic year now since about 2-3 months, but these numbers are looking at last year when we just launched this after the Vancouver AAP. So about 85-86% of programs have already implemented this at that time when we're looking back in the previous year. So about 15% of programs did not implement it completely. Which classes have received didactic training in the new classification? So when I look at the second and third years, almost 90%. First years, half and half. The interesting part was the fourth years, about 2/3 of the programs decided to educate last year's graduating class on the new classification as well. Now, this was didactic. When we look at clinical training, obviously the first years may not have that much exposure. Almost basically 100% of the third years were exposed clinically to the new classifications. Almost half of the second years. The interesting part for me when I was looking at the data is about 93% of the fourth year graduating class in the clinic, they were exposed to it, but only about 2/3 of them were given this in didactic format, which kind of brings us up to another point. I'm going to talk about different formats. So have you performed calibration exercises with the selected individuals that teach periodontics in your program. So 80% of programs have done calibration exercises. 20% have not done so yet. Have you performed calibration exercise or held informational sessions for the general dentist who teach non-perio lectures and or supervise non-perio activities? So basically, this is not targeting that yellow bar, which was the general dentists who are teaching perio. This is everyone else in your institution to see if there's an awareness about this. And the numbers look good. 3/4 of the programs have brought awareness within their institutions regarding the new classification to people who do not necessarily teach perio. Did you increase the credit load of your courses in order to introduce the new classification? Pretty much almost 95% did not manage to kind of squeeze it in. 5% of the programs did actually increase some credit load to be able to put some time on this. 50% managed to do this with less than 3 hours of didactic. The other 50% took about 3 to 5 hours of the extra didactic time to implement the new classification. Now that time, 50% of the programs added additional mandatory lecture hours, while 12% added optional lecture during lunchtime or after school outside of regular curricular hours. There was about 5% that did an online self-educational style. But a lot of them, we see a different variety, and I can't see my notes here for what the other was. I apologize. I'll get back to you for that one later on. It's not showing up here on mine. How did you manage the graduating students, the fourth years that we were looking at? So almost 50% did not introduce them to the new classification as part of their curriculum, which could be understandable because of the workload they're going through, their timing, they're going through their boards, and a lot of time for those students, they're almost thinking, I don't need to know this, I'm leaving. So that's something to think about, how we could be addressing this, because when you think about it, that basically means 50% of the dentists that graduated 2-3 months ago may not have been introduced to this. So that's a potential opportunity for us to look at. 15% provided an optional after-hours CE style. Another 15% provided a mandatory seminar as part of the curriculum. And again, I don't have the others here, and I'll get back to you for that. So rate the extent to which you agree with the following statement. And this was interesting because this helps us get your perception as the leads in your education institutions. Sorry about that. The new classification can be used as a communication and collaboration tool in the pre-doc programs. So about 70% agreed or strongly agreed. The interesting part to me was about almost 20%, 16, 17%, either disagreed or strongly disagreed. So again, I see those as opportunities that we should look into to better understand, because I believe as the educators, doesn't matter what step, what level, where you are in your institution, but as periodontist educators, I think we need to have a united front when we're approaching this situation. So I think it's very interesting to get those perspectives, so we can use those as opportunities for ourselves. Again, the new classification provides a unique opportunity to optimize patient care by focusing on prevention, treatment, and referral. When we look at the numbers, about 60% agreed or strongly agreed, and again, about 20% disagreed or strongly disagreed. Please rate the extent to which you agree with the following statement. The new classification can be used as a communication and collaboration tool. And this could be amongst the perio department, amongst multidisciplinary approach between the perio department and others. Almost 70%, again, strongly agreed. 12% disagreed or strongly disagreed. So I'm sharing this with you just because it'll give a perspective. So when we do have the breakout session, some tables will be addressing this. So I'd like for everyone to get involved and have discussions regarding this, so we can shed light on all different perspectives and different experiences people have had. Do you believe you've achieved best practice for implementing the new classification in the inaugural year, basically? Almost 80% think it's too early. It's work in progress. 16% think they've kind of mastered it. I'd love to hear from those people, because we definitely haven't at our institution. Now, these two questions, please share your unique circumstance and or challenges that you faced, and the following, which is any pearls of wisdom. I'm going to come back to these because I don't want to steal the thunder of our speakers. We have two wonderful speakers here with us this morning who are going to be discussing their experiences, sharing their pearls of wisdom and also challenges that they faced. And they each represent a unique style of practice, educational setting. So we're going to start off with Dr. David O'Connell. Dr. David O'Connell graduated from the University of Nebraska Perio program. He is a American Board of Perio diplomate. The unique situation he represents was he was in private practice for 30 years in Wyoming before he transitioned into full-time education academia 4 years ago. He teaches at the University of Utah School of Dentistry. He's the section head. And Dr. O'Connell was recently elected as secretary-elect for the AAP, and he will be installed in his new office this coming Monday. So it's great to have an educator in the high ranks of the AAP. So please help me welcome Dr. O'Connell.
Okay. Well, I'd like to thank the AAP, and thank you for that kind introduction, Dr. Karish. I'd like to especially thank the Educational Committee, because I am a newbie at education here. I've only been doing this for 4 years, so it's quite an honor to speak before this group here. I'd like to get through the no disclosure statement. I have no conflicts of interest at this time. And as Dr. Karish says, I am at the University of Utah School of Dentistry, and I joined the school. We are a brand new school. I joined them 4 years ago. We've graduated 3 classes so far. Our enrollment is about 50 students per class. We have no graduate students, as mentioned. We have 2 full-time periodontists, but we're down to only me because we have an open position at the school at this time. So it's up to myself, our 2 full-time dental hygienists, and our 2 one-day-a-week adjuncts, who are very, very helpful. So we are covering everything from the classroom to the clinic, and we're trying to do that as well as we possibly can here. Now, the new classification system that was rolled out last year has been the basis by which we have changed our curriculum quite a bit, and it's been very, very helpful and I think very useful to the students. As we rolled this out, we started out with gingival health, gingivitis, periodontitis particularly in the middle, and the peri-implant conditions and peri-implant diseases. That's where we started. And then we moved to the green outlines of the other periodontal conditions. So we've covered all 15 boxes within our school following the rollout last June. We initiated the care among all 4 classes, but in various stages depending on where they were. I'd like to spend just a few minutes on some of the other conditions, and then we'll talk about the staging and grading quite a bit. So some of our experiences we've seen is we've had a little bit of challenge with the new terminology. The violation of supracrestal tissue attachment doesn't roll off the tongue quite as well as violation of biologic width, but that concept is certainly alive and well in our school. And in fact, with our school, we actually charge only $100 for crown lengthening surgery just to be sure that the students are able to do the proper treatment and get good patient outcomes. So the concept of violation of supracrestal tissue attachment is certainly very much a focus of our education, particularly on the clinic floor. Now, mucogingival conditions, the gingival phenotype versus gingival biotype, we've moved into the gingival phenotype fairly easily. And the best way for us to share that information was the visual test. So we instruct the students, place the probe in the marginal gingiva. If you see the gray hue of the probe outlined, as on the left, then that's a thin phenotype. If you don't see the gray hue, then that's a thick phenotype. In this particular case, is from the same patient. So they understand that it can vary in different sites for the patient. So this has been very helpful to get the point of a thin phenotype across. The RT1, RT2, 3 gingival recession designations have been very helpful as the students have looked at the different recession types, particularly with regards to how much root coverage can be expected following a connective tissue graft. So RT1, 2, and 3 have been very, very helpful for our students on the clinic floor. Now, peri-implant mucositis, peri-implantitis, the criteria that are established now have been very, very helpful for the students to identify when you have a mucositis versus an implantitis. And they have very differing modes of treatment and expectations for those. So I'm not going to spend very much time on this other than to say the classifications have been very helpful for these two diseases. The last thing I want to talk about and I'd like to focus in on number 2, because this has been a paradigm shift for so many of our general dentist attending faculty and some of the periodontists that I've talked to out in the practicing world. Number 2, there is no credible evidence to support the existence of abfraction or implicate it as a cause of gingival recession. That's a huge paradigm shift that has been very challenging to overcome within our institution. So let's move on to staging and grading. We have introduced this to all classes during the academic year last year at various times. We felt it was really important that the D4 class get this information before they graduated, and we got it to them in April before they graduated, because a couple of months afterwards they might be encountering this terminology, and we felt they really needed to understand this. So all 4 classes have received this both in the classroom and on the clinic floor. But we also continue to teach the 1999 classification because our notes, even though we're a new school, our notes are going to reflect the 1999 classification in most instances. And we also felt that as the students graduated, went into their various practice settings, they would have to understand what that terminology might have meant from the past. So that's why both 99 and 18 are being taught at our school. Now, the biggest thing is we emphasize risk, as outlined by yellow on the screen. So that's been the biggest game changer for us, is the students recognize that not all periodontal disease is the same, that the risk is what we really need to consider as you evaluate your patient. You're all familiar with the staging and grading tables from the AAP. These have been best sellers with the AAP. They are taken very regularly when we bring them on the road to other areas and meetings. But we've taken this table, we've modified it somewhat. While on the board, Dr. Kornman gave us a lot of information in May, about a month before it was rolled out, to explain a lot about the staging and grading. And then I attended a meeting at the Midwest Society of Perio in February 2019 that gave a little more clarification. Dr. Kornman wanted me to share with you that you will see a lot of these concepts in which we've modified on the tables that coming up in an upcoming J. Perio article. So this is coming up, and I think this will be very helpful for you to understand some of the nuances with staging and grading. So we've taken this table at the University of Utah, and we've modified it somewhat with a few explanations. As you all know, stage 1 through 4 is very closely correlated to cancer diagnosis in terms of stage 1 versus stage 4. And Dr. Kornman mentioned that with stage 1, fairly early disease involvement, relatively easy to treat through scaling root planing. But stage 3 and 4, you cannot expect scaling root planing to be the sole treatment for stage 3 and 4. And right to the red line is the stage 3 and 4. And that's been very important for us at our school because the students are supposed to reach out to the perio department anytime they had a stage 3 or 4. So as Dr. Cornman mentioned, 70% of your patients that you'll see are likely to be in stage 1 and 2, and 30% will be stage 3 and 4. What's been particularly helpful, if you see on the stage 3, 4 at the bottom, our students had a lot of trouble, said, what's the difference between 3 and 4? They're both severe periodontitis. Well, with stage 3, you're in danger of losing the tooth, and stage 4, you're in danger of losing the entire dentition. So when he correlated it to terminal cancer, stage 4, the terminal dentition for stage 4 is something that seemed to have resonated to the students. So that potential for tooth loss has been very helpful versus potential for dentition loss. Now grading, Dr. Corman said, default to grade B until proven otherwise, and that's what we've seen. Most of our patients, at least within our clinical setting, are definitely grade Bs, a few grade Cs, and with our patient population, very few grade As. So most everybody's going to be a grade B. Now, looking at it individually, the interdental clinical attachment loss, 1, 2, 3, 4, greater than 5, that's been pretty easy because it's a carryover from the 1999 classification. The radiographic bone loss is new and different. That one, I think, has been very helpful with the radiographs. It also has maybe some concerns. The division of the destruction based on the corona 1/3 and extending into the middle 1/3 has been helpful. First 15 or less than 15% root bone loss is stage 1, up to 1/3, stage 2. Once you get into the middle 1/3 or beyond, it's stage 3 and the vertical defects. My concern is the very bottom, and this is what we're seeing with some of our attendings. I think there's going to be a little potential to regress to the diagnosing of periodontitis on the radiograph. As helpful as it has been to look at the bone level on the radiograph, I believe that we're missing out with some of the stage 1 cases that may not show radiographs. So the easiest way that we found, and this is a tip from Dr. Kornman, is he called this the ladder technique. So we've developed a ladder dividing the corona 1/3, middle 1/3, apical 1/3. And it's very different on a very short root of those central incisors versus the normal root of the lateral incisor. So for example, if you had 3 millimeters of attachment loss on that central incisor, that may be into the middle 1/3. And that tooth's in danger and at risk for the future. And that's now a stage 3 periodontitis classification. So this has been very helpful for our students as a visual for them to understand the importance of looking at the different 1/3 of the root. Now complexity, this is on the table. The horizontal bone loss will be very common for the stage 1 and 2, and then the vertical stage 2 and 3. What we've especially used the stage 4 is the number of teeth that remain and the opposing pairs of teeth. So you may have a case with perhaps only 3 to 4 millimeters of attachment loss, but if there are numerous missing teeth due to periodontitis or upcoming loss of teeth due to periodontitis, we've downgraded those cases to stage 4. I'll be interested to hear what you are doing at your institutions because that may not be consistent, but that's been our interpretation, that once you get to that point of so few teeth, the rest of the periodontium is certainly at risk for periodontitis. And the panoramic has been very helpful to just count the number of opposing pairs of teeth to get to a stage 4. With regards to the extent and distribution, that's a carryover from 1999, so that's been easy to reinforce with the students with our new staging of 2018. As we go to grading, because we're a new school, only in operation for 3 years, we don't have 5 years of records to see if there's 2 millimeters loss over those last 5 years to put them into grade C. But what's been really easy for the students is they look at the worst tooth of bone loss, they get that percent bone loss divided by age, and then they get to the ratio. So that ratio has been very easy to determine so they can place the patient in the proper grade, at least in terms of the progression of the disease there. Now, in terms of the grade modifiers, the systemics, this has been fairly easy for the students to recognize the glycemic control and the smoking risk that the patient might have. So that's been straightforward, but it's been really helpful for the students to be sure and check into the diabetic status of their patient. So that's how we've introduced it on the floor. Now, what's been our experiences with our students? Maybe not exactly what we hoped for coming out of the classroom, but I'll just share some of the comments that patients have. I don't know why they changed. It's still treated with scaling root planing. Obviously, we didn't get to that student correctly. Now, the last two are a little better. They say, well, I understand perio surgery is probably going to be recommended after I do my phase-on treatment and do my reevaluation. And also it's right of the red line. That's something that's a patient needs more treatment. And definitely when we really know we hit the student properly was, I need to refer to a periodontist right of the red line, and I'll make that determination after my reevaluation to consider a periodontist for help. Now, they've had challenges with clinical attachment level versus clinical attachment loss. Sometimes they focused in only on one criteria, 4, 5, 6 millimeter probing depths or mobilities. They just look at one thing, and that's the issue, the shades of gray with this here, and that they need to look at everything to come up with the appropriate classification. And they're still adding chronic, especially to our D3, D4s who learn 99. They may say, I have a stage 2 grade B chronic periodontitis, so we remind them to take that chronic out of there. They're still wanting to do a generalized stage with a localized stage like 1999, so we're trying to break them of that habit a little bit. And then in terms of the grading, sometimes they're looking at just the rate of progression and not the systemic, or the systemic and not rate of progression. So we're emphasizing you need to look at both to come up with the grade. I think we've also had some challenges with them understanding that maybe a stage 3 grade C at age 30 is a little different than stage 3 grade C at age 60. So the aggressive periodontitis concepts are still in their mind. And consideration of smokers. What do we do with smokers? And now especially vaping, because Utah has a particular problem with vaping. But however, overall, the good news, they've adapted well and quickly. They certainly understand the patient's unique needs a whole lot better, and they've incorporated the concept of risk as they're evaluating their patient and treatment planning. Now let's talk a little bit about faculty challenges here. Probably the number one challenge is not picking up the perio probe, which happens not infrequently here. Or they may say, I don't see the bone loss on the x-ray. You don't have a perio case, periodontitis case. Therefore, you do scaling or adult prophy, not scaling root planning. It's been very interesting to see the different ages of the careers of our adjunct general dentists. The early career, they've adapted very well because they were familiar with 1999. Mid-career has been a little challenging. And I use mid-career because I was on the task force to evaluate the annual meeting, and those were the folks that were most disgruntled with our meeting. And that seems to be a very challenging group to work with at our school. At that mid-career range. Late career, some of those folks are great. They're CE junkies. They can't learn enough of the newest and greatest. But we also have a few adjuncts that might be about 4 generations behind. I have one attending who actually talks about periodontosis. And the private practice world comes in. We get paid by treatment, not diagnosis. We just want to get to work. It takes too long to do that exam. And worst of all, even though some of our adjuncts know the stage 3 and 4 grade Cs are supposed to reach out to perio, some of them have actually said, you don't need perio, I'm a licensed dentist, I can help you. So that's just been an observation. And with the school, we're a generalist based model of dental education. We don't have the opportunity to oversee their dental or their perio exam, diagnosis, and treatment plan. It's not till they begin therapy that we make the corrections for accurate assessments and diagnosed treatment planning. And without a graduate program, the students don't see the benefits of perio surgery, limited opportunities to do perio surgery. And our patient population simply doesn't have the means to do perio surgery so that they could see benefits of phase 2 perio surgery. And our Medicaid population doesn't have that. So that's been our experiences at the University of Utah. I think I'll hold off questions until the Q&A session. So I'd like to thank you. I really appreciate this from my days at Nebraska through my career in Wyoming and now at the University of Utah. Thanks so much.
Thank you, Dr. Ocano. I think our students are talking with your students with those comments. Doesn't matter what you do, they all need root planing. That was a great insight. I'd like to ask Dr. Frank Roberts to come up and share his experience. Dr. Roberts he's the acting chair and pre-doc director at the University of Washington, Department of Perio. He's the director for the Regional Initiative in Dental Education. He is the chief of periodontics, Seattle VA Medical Center. Dr. Roberts got his DDS from University of Tennessee, his perio and PhD, University of Alabama in Birmingham. His interests are genetics of disease susceptibility, genetics of immune response, educational methods, and rural practice training. Please join me to welcome Dr. Roberts.
Thank you very much. I think listening to Dr. O'Connor, you got exactly the challenges we have. I think if we could get you to do some kind of panopto voice over your slides and record it, would people be interested in having that in there to show their perio departments? I mean, you're getting in exactly what the challenges that we've had, so I really appreciate exactly what you got into. So yes, Frank Roberts, I'm really glad to be here today. We're going to talk about, University of Washington has a graduate program, a very illustrious history in our graduate program. We've been there since a little bit before 1950. So it was interesting to see a dental school that's, y'all started about, you said you had 3 graduating classes, so 7 years ago, something like that. And so they have challenges with people being set in their ways in that 7 years. And I wanted to read one of so I sent out the classification, classification training out to our faculty because I thought, maybe they might want to know what the classification system was. And I got back an email. I guess it's fine as far as it goes, but as you know, I consider the whole new grading system a waste of time clinically. It's okay for research purposes, I guess, but it's counterproductive for clinical use. Simply unnecessarily complicated and time-consuming. There are no cases I can't quickly classify as mild, moderate, or severe, localized or generalized, adult or rapidly progressive. The 1987 World Workshop was really when they had it right. So that's where we were starting. He's 82. But he's good. But it's interesting to try and put some of those things in. So I was going to talk about our approach, and I'll say that, and today I have Diane Daubert here with me, and Diane, if you don't mind coming to one of the microphones, and Diane's gives our lectures on perio classification. Dr. Daubert gives our lectures on perio classification and was also giving them to the general dentists in Washington at the Pacific Northwest Dental Conference, which is a big conference. And also Jessica Latimer is a 4th-year dental student applying for perio programs. And Jessica, if you don't mind, maybe you could go to the other microphone. Jessica put together the tutorial that I'm going to be showing you. So if you need something computerized, ask a student to do it, especially an outstanding student, and they can really help you. And I appreciate all the great job Jessica did. And they can answer some questions as we go. So basically in 2019, we took a different approach kind of for each class. In our first year, Diane just did those lectures. We focused on all the perio and peri-implant conditions. Maybe one of the interesting things is our attendance at lectures was 100%. So first year we get great attendance. We did a quiz on that thing, and they did pretty well. Really just a broad overview of the different classifications, including implants. Then in the second year, we just reinforced that by having them put their diagnosis in the SOAP case. So we had to give them some background information to do that. And I'll say we waited until this year to do, in graduate program, we went ahead and did the classification starting in the fall last year. But when we came to I went to the grad program directors meeting last fall, and there was a fight in the room, and I couldn't tell that we were going to keep the classification by the end of it. So I said, we're not going to start this in pre-doc until I'm sure they're going to do it. And it was between the people that were authors of the paper. So I thought, well, let's wait and see. I don't know if any of y'all remember that. But anyway, so we decided to wait on the dental students until this year. Then in the third year, which at our school is a clerkship model, we started now really in on focusing on diagnosis, staging, and grading. Again, we had 100% attendance, and these students are really enthusiastic. They're so happy to be out of the basic science classes and all that, so they still come to class. Diane gave those lectures with interactive polling. She could say something about that. And then we, of course, had the clinical application. And then notably, the perio interest group, which is a dental student group, which Jessica is the head of, brought donuts. So that was maybe one of the more important aspects of that lecture. And then in the fourth year, which is comp care at our school, comprehensive care at our school, we did diagnosis, staging, and grading. And then we also had to explain how this fits in with what we'd already taught them and how the changes from the previous classification. We did more of that with the fourth year. Now the lecture attendance was down to about 50%, and some of that is because students are out on rotation. I think there's maybe 8 out on rotation for any one lecture, but for some reason there was more like 40 gone. And also with interactive polling. And then Jessica created this online tutorial, which had exercises in it. And then we had an online quiz that they had to do. And I'll talk about the results of that in just a minute. And we did that in Canvas, and they ended up with about a 76% as their score. And some surveys about that, and then a clinical application. They're starting that, they started that this fall. How do I do just click, sorry. So this is Diane's lecture, one of Diane's lectures. She started with the polling. What do you think of when you hear perio classification? I liked, sorry, I forgot. These are these word clouds, which are interesting to get kind of feedback on what people are thinking. Why do we need the classification? Going through those topics. Basically taking things from the various papers. We gave them to read the main classification paper, and then the flowcharts from the Tenetti article, and then the tables. Highlighted it, and then again, as Dr. O'Connor was showing, this classification, especially for the first years. And Diane, do you want to say kind of what you did with that?
Yeah, one of the really nice things about this, especially for our techie students, is that the paper allows you, when you have the paper downloaded, to hit all of those links you probably all know, but all they have to do is hit the link. They don't have to go searching for any article. It's right there. So they really like that, and we just followed this format, went through each one of the different types of conditions, but allowing them to access each of the individual papers through the main paper.
Yeah, great. And I liked how Dr. O'Connor split it up as you're going through the class. I think that's a really good idea. Then we took things from the articles, but then added clinical pictures. And I think that was a huge help to that. And that's what I would suggest y'all do as you're doing it, whether you're describing the various stages, X-rays, clinical pictures, I think was really helpful. Then we had some cases. So things are getting more case-based in our curriculum as they are for their future boards. So we're trying to do more cases, and then give the students chances with the online polling to kind of give their ideas. And when you do the polling, it makes them make a decision. So I think it really helps them realize what they do and don't understand. This case is neat because we actually had almost 40 years of follow-up on this patient. And that's one of the great things. Our program, we save all the patients and follow them, and we have up to 50-year follow-up on some patients. So that's really nice for the students to see what really severe disease, and then the patients actually have a lot of their teeth, or almost all of their teeth still. So it's also getting them to understand long-term how perio can help.
And I think that's sorry to interrupt, but one of the nice things about having this robust maintenance program in our grad program is that we get to see patients that have been treated surgically, and then you see the grading. So as opposed to a program that doesn't have a grad program where maybe nobody's grade A, we actually do have these long-term cases that have been treated for 40 years that are actually grade A, because we can see no progression of bone loss.
That it hasn't gotten worse, so it's nice for them to be able to see that. Yeah, exactly. And I think Jessica has some comments about that too. So here's some of those feedback, and we use Poll Everywhere at our school. The school has a contract with Poll Everywhere, so it's free for us. But where the student gives their, whether they have periodontitis or not, and they did pretty good with this. Then as it got into it, again, what do you know, surprises, having challenges between grades 2 and 3. And I think you saw that too with the general dentist.
Yes, definitely. When I presented it at the Pacific Northwest meeting, it was mostly general dentists, a few periodontists, a few hygienists, but it was really difficult to make that decision, and lots of good discussion about it. So if you have one class 2 furcation, does that make it a, stage 3 versus stage 2? I mean, it's really hard because we don't have the option of localized versus generalized.
Right. And you can see in grading, again, they had some challenges with deciding on that. This one, here's what is periodontal maintenance. So these are these word clouds. So you say, what is periodontal maintenance? And they can answer with whatever they want. And you can see their most common answer was Gerardo. And that's in fact a name of one of the students in the class. And so as his name came up once, then everybody saw it. So then everybody started typing Gerardo. So it was one of the more common answers. So you can see you get what you want, but it can go awry a little bit. And it can also go way off the rails, and they're actually in Poll Everywhere, in many of the polling softwares, there is a chance to have somebody that edits things before they're allowed to show up. So if you think they're going to be out of control, you can have a student do it or something where they're seeing their responses and have to approve them before they go up on the board. But Gerardo, we didn't think was too bad. Hopefully they're professional, so it won't go too off the rails. But anyway, it's an interesting way of getting what they're thinking, and I thought was pretty eye-opening. Then I wanted to show you the online tutorial. So this was created by Jessica Latimer, who's a senior this year. We did this for the seniors, but now we're providing it to everybody, including the faculty. It's just going through the classification system. This was done in soft chalk. And I'll put a link at the end. You're welcome to look at it. We are also willing to share it if people want it. You'll have to put your own cases in, but you can see here they're trying to sort cards between suspect periodontitis and periodontitis not suspected, whether it's class 5 caries, whatever. They have to choose those things. Here's one for extent. Again, they read about extent, and then they have to sort extension things like missing 6 teeth due to periodontitis. What stage would that put them in? So the students really love this kind of stuff. I don't know if you've met students now, but they actually aren't interested in reading. They aren't interested in, they want online stuff. And so this is what we created. This is the same case. And so the students got Diane's lectures, then they get to see these same cases again and a chance to think about them again, which I think has been really popular. You zoom in, they can look at the charting, then they have to answer, is this a periodontitis case? And they can check their answer. Correct, it is, and it tells them whatever. If they get an incorrect response, there's actually feedback for incorrect answers as well. I'll show that again here. What stage of periodontitis would you assign to this case? Stage 3, correct, incorrect, and see, although the patient has attachment loss of 5 millimeters or more. Anyway, you get the idea. Here's those same cases again. And we put in about 3, and students really liked the cases, so I think that was really helpful. Again, I'll give this link. And then at the end, it does a quiz to them, and then it gives them a chance to get a certificate of completion. It also, with the embedded score center, it tracks utilization, so you can see who did it, and I can see which faculty did it, which is helpful to me to know. So anyway, I really appreciate, Jessica, you're gonna talk about the data, I think. So we did the UW-ADEP study, which was studying this tutorial and seeing if it was working. Again, Jessica Latimer, Ashley Huynh is a second-year student. Mike Giardino is a perio resident. He's also a grad of UW Dental School as well, Dr. Daubert and myself. And we got basically between almost all were either agree or strongly agree that they enjoyed using the online learning modules, found the use of the education more effective than traditional lecture alone. Big shock. They understand how to diagnose, maybe. Let's see how they did for that. Yeah, most of them agreed, so that's good. After completing the module, understand how to stage and grade. Again, pretty good. Feel prepared to use the perio classification system in a clinical setting. The learning methods were interesting. So we gave them the reading, like I said, we gave them the main article, the Tonetti flowcharts and the tables, and no one read them. They did use the online module, which was great, and attended them if they decided to come to class that day. And how they rated it, again, rated the learning module, the online module the highest, and then lecture, and then finally reading. So it's great to have the links to the reading, but they got to actually click on them, and then they actually have to read them. Students, what did you like or dislike about the module? Students liked it was interactive, it was organized, it was convenient. They could do it at night, they could do it from their hot tub at home and from their cell phone. They didn't like the flowcharts. That was really, I think it was one response of a student didn't like the flowcharts. He was like having a heart attack related to flowcharts. I don't know what the issue was actually. But they wanted it more where the questions were on the same page as the case so they could see the question and see the case at the same time, which is a challenge to do, but we'll have to figure out if we can do that in a future version. And they wanted to have the charts. So what I did was I sent out the link to the quiz, and then I sent out just the PDF of the charts and said, look at the charts while you're doing the quiz. And they said, couldn't see the staging grading charts during the quiz. I'm like, well, I don't know what else to do. So anyway, welcome to 2019. What challenges did you encounter while using the new classification scheme? And Jessica, do you want to say something about this?
Sure. So mainly I think that people were confused about grading and using radiographic bone loss because you're using that in staging as well when you're looking at the coronal thirds. And then when you have stage 1 versus 2, you're looking half of the coronal third, so like up to 15% or 15 to 33%. And then when you're also looking at someone with bone loss over age, that was one of the other comments, direct versus indirect evidence. I don't think that students really appreciate what that means, and when they have a new patient that presents to the clinic, to know to use indirect evidence and use the bone loss, percent bone loss over age. So I think that was some of the more confusing aspects of the staging and grading system for the pre-doc students.
Great, thank you. So anyway, they want more. Here's the link. I didn't really understand what this picture meant, but anyway. Barbie visits Chicago. I don't know. Anyway, thank you very much. You're welcome to get the try this thing out. And then we can provide the soft chalk module link without the cases if you're interested in that. This will be up for maybe a couple weeks, and then we'll put up one without the cases in it, and then you can link to that anytime or contact us if you want help with that. All right. Thank you. Yeah.
Thank you, Dr. Roberts. If I can ask Dr. O'Connor to join us up here as well. So let's take about 10, 15 minutes. We'll open up the floor to Q&A. Any questions you have, just please come up to one of the mics so everyone can hear you.
Yeah, Tom Kirchie, Virginia Commonwealth University. Dr. O'Connor, you commented that you thought that the x-rays, that you might be missing some stage 1 just because they look at the radiographs instead of the attachment levels. Our experience has been almost the opposite, that our students have a hard time identifying where the CEJ is and tend to underestimate where the CEJ is, therefore overestimate disease. And sometimes we have to temper them back and say, well, you know, you're really overestimating it, so really carefully look at the x-rays. Have you experienced that problem? Because we tend to have more overdiagnosis than underdiagnosis, I think.
I would agree with your comment that you're overdiagnosing the situation. And at the initial examination, because of the inflammation and the lack of resistance to the probing forces, they are probably probing beyond the actual attachment. So they're classifying a lot of the patients into stage 2, moderate. And then at the reevaluation, we look at the attachment levels and we think, well, this is actually more consistent with the stage 1. So I would agree that I think we're overdiagnosing initially. And at the reevaluation, and I know we're not supposed to bring it back to a different stage, but in reality, I think a lot of those stage 2s are truly stage 1s. And that's when we make a modification to the classification.
All right, I had one other question, but I'll let Dr. Go ahead.
Can I make one comment about that too? So interestingly for us, we say if you think it's a prophy, we need to see it. Perio needs to see it. If they find deep pockets, then we say go on and do your perio evaluation. You can have them go through perio and all that. But we say where we want to see it before they go any further is if they call it a prophy. Because there's so much, we have the opposite thing. We have so much underdiagnosis that everything's called a prophy. And so we say perio needs to sign off that it is a prophy. If they think it's severe, then we're not worried. They'll go through all the steps of perio.
All right, so my other quick question, again, to Dr. O'Connor. You had mentioned in grading, you had them look at radiographic bone level divided by age, and you look for the worst area. I've struggled with this, and our students are too. When we're diagnosing, I'd like to know what other people are doing, because for attachment levels, you're supposed to find the worst 2 non-adjacent areas. And it really never says how much, where you need 2 non-adjacent areas with radiographic findings, or is it the average, or what it is? I'd be interested in knowing what you're teaching.
That's a very good question. And we struggle at times in terms of, okay, which area radiographically are you going to choose to come up with that ratio? And you're exactly right. It's 2 or more teeth in terms of attachment level. but we are deferring to the worst area simply from the standpoint of risk. I might be wrong, and I would love to hear the comments coming back later as to what would be the more appropriate utilization of the staging grading tables to come to the proper classification. So I'm here to learn from all of you also.
I have a question. Oh, I'm sorry. Go ahead.
Good morning. David Puckett from East Carolina University. Great presentations, Dr. O'Connor and Dr. Roberts. And I applaud the Education Committee. I was a little underwhelmed when I read the topic, but actually this is very timely that we have this follow-up discussion on the classification system. I just want to get a little bit more in depth on implementation on the clinic floor. Just your experiences with integrating this classification with the electronic health record. And second question, talk about calibration and implementation across extramural sites. Many of our programs have our students, third or fourth year, rotating at sites around our states or regions, how to make sure that they're being taught and let's say accountable for utilizing the system uniformly. So comments on those two things, EHR and extramural sites.
We are, at the University of Utah, we're just moving to EPIC and the electronic chart that merges with the medical record. It's been a work in progress, and we were the first school, so I can't comment on that. I'd have to say that it's not something that we're involved with at our particular school, and I feel like we're beta testers for this program working live there. Now, secondly, in terms of the outreach clinics, I'm dependent on the directors of those outreach clinics to actually implement this and hold the students' feet to the fire that they're supposed to utilize this. Some of the dental students' comments to me are, oh yeah, the outreach clinics, dental school light. And essentially, some of them are doing this very well, depending on the director of the outreach clinic, some are not. But we are emphasizing you must still come up with the proper classification, regardless of where you are. I would say probably about 50% of the outreach clinics are actually doing this in those particular sites.
So we have Axiom for us, and it's actually just part of our form for the perio form, and the only place is different is just in the diagnosis section. And I almost feel like we need to have three separate things: insurance, what they said before, and then the new classifications, but we're just putting it in the diagnosis section of that form. And you can add staging grading, at least to remind them of that. So we also have a big outreach program, and we have less challenges with the sites adapting to whatever we ask them to do. It's pretty intense continuing education, but that being said, we're just starting to implement this now. So we're trying to get it in the school. Once that gets figured out, then we'll do it in the sites, and we do a continuing ed with them each year. But I think really we're gonna need to have some online modules that people can use at sites, that people can use with their faculty. I think the faculty want something online that they can practice with so that they're not feeling stupid or anything else, whether it's general dentistry faculty, perio faculty, whoever, they need help walking through things. So I think we should create that probably from the academy side to help people know it, not expecting people just to read it and do it. And we'd be happy to help with that.
I think there was a good point brought up about staging with stage 1 versus gingivitis. We have a lot of problems where the students will say, there's 6 millimeter pocket depth here, and they say it needs scaling and root planing, yet when you look at all of the data collection from the clinical examination, you realize that the gingival margin is located on enamel. And so going back, you mentioned that you use Axiom, you can go into Axiom and instead of recession, put plus on it so that it really shows it helps them to make a differentiation between true bone loss attachment level and just pseudo-pocketing. So I found that. Now, another question related to Axiom is, have you changed all of your diagnoses to the new classification, or have you been holding on? We have Ryan that comes, I think one of your group still held on to the old gingivitis, periodontitis, aggressive periodontitis, and then added the new classification as well. See, I felt like that held us back. Is either like jump in and let's just have the new classification on Axiom straightforward.
Yeah, so we're using, you're asking me, I think, so we're using the new classification, but we also have to give an insurance classification so
Yes.
that the billers can, so we can get paid for it.
See, that
Little
really is
things.
difficult for the
Yeah.
students,
Yeah,
because I think
don't-
it lets
but
them
they have to
stay
do
in
the
the
same
grade
thing in
zone.
their office. They
Yeah.
have to do the exact same thing. They won't get paid if they don't have that. So we feel like that's a disservice to them to not give them that part of it as well. So we
Okay.
have to be realistic, I think.
Good, because I
along
think
with-
then we'll hold on to the old ones too.
Yeah,
Thank you.
unfortunately.
If I may follow up, your comment about the probing depth. If you look at the tables, it says stage 1 for 4 millimeters, stage 5, 5 millimeters, stage 3, 4, more than 6. So that's when they look at that number alone, and that's why I told them you can't look at just one parameter, because it could be gingivitis, just as you suggest. The other challenge we also have is we're very much a Medicaid school, and Medicaid's reimbursement for our school is if it's a 4 millimeter probing depth, regardless of attachment level, you're going to get a benefit for that. If you don't have 4 millimeters, you're not going to get paid from Medicaid. So it almost totally undermines our educational process in terms of coding or submitting based on a number, not diagnosis treatment planning.
Yes, thank you. Andy Brower, Chicago. So I have two questions. I'll give you the second one first, because it's for both of you. And it really goes to how long are we going to continue to teach legacy diagnoses, okay? Because I think by the time after the 1999, I mean, I was still seeing juvenile periodontitis 5 years ago on, current practice board preparations. So that's the second question for both of you. But my first question is for Dr. Roberts. Again, legacy diagnoses and this thing about the ADA insurance classification diagnoses. They used to be in the perio terminology. It was abandoned in 2003 with the terminology, I think it was version 4 or 8. The CDT code number 4 abandoned it in 2004. So, are you aware of any insurance companies specifically that require it? Because honestly, for the last 15 years, I had not had a carrier ask me for those. So I'd like to know, are there actually carriers that require it?
Delta Dental asks us for it. Delta Dental asks us for it.
Maybe the academy needs to approach them,
Yeah.
I think.
Your question about legacy diagnoses. For the foreseeable future, we are going to continue the 1999 classification and the 2018, and that's because insurance carriers are still on that. In fact, while I was in practice, we still got questions about type 1, 2, 3, 4 periodontal disease. Type 1 being gingivitis, 2 mild, moderate, and severe, 2 to 4. So yeah, that was prior to 99, and yet up until the time I left practice, I still had to give them a periodontal case type to get reimbursement. So that's why I think the students need to have an understanding of at least the 99 and 2018 for a few years probably, unfortunately.
State
Okay.
boards and NVDE as well. Yeah.
Bob Bitter from Southern Illinois University. First of all, I'd like to compliment our speakers on their presentations. I thought they were really excellent. And David, I certainly hope that you would share your PowerPoint here. I think that would be tremendously helpful for us to take that back to.
Talking over it, I think explains it better too.
Yes.
You can really follow it. If you could know how to do that, it would be great to record it with you voicing over.
I am happy to share that information. If it's helpful, by all means, it's readily available.
Well, thank
to all
you,
of
thank you. I'd like to just share that at Southern Illinois University, a couple of our faculty members took the time to actually develop something we could bring into the clinic, and it's a clinic module. We have Axiom, so it's now integrated into that format. And what we did was those individuals took each of the various classifications, went through the entire manual and basically looked at each particular question that was being asked as to how you might go about distinguishing each item as you go through and evaluate it, and then create a drop-down box basically with the same values that were in the papers, so that as you go through, it makes it much simpler to go through and develop a diagnosis, as opposed to having to have maybe a couple of sheets in front of you and trying to look at each of those and decide that. So it takes and then summarizes all those, and you can very quickly then decide what's appropriate. That said, I will say that at times I feel we get a certain degree of overdiagnosis as far as the severity. It's challenging sometimes because in some instances we're looking at tooth loss, and the students assume tooth loss is tooth loss and don't recognize that, well, there's periodontal tooth loss and then there's restorative tooth loss. And if you confuse the two, you're going to create a situation in which you're not accurately estimating what I think the individuals who authored those papers took into consideration when they created those particular points to evaluate. And I'd be happy to put anybody here in touch with a couple of the people that have put that together for us. I'm sure they'd be happy to.
It's a one-pager or something, or it's a?
Well, it is. It's a single page, and each time you go through, when you click on, for instance, a periodontitis, then several choices come. You hit that, and then a whole group of other things come, and you have to answer each of those. After you've done that, those still remain on the page, and you see that in Axiom.
Oh, wonderful.
And then
Yeah.
below that, it'll ask you to summarize now what you've calculated for each of the tables and make your diagnosis.
Very cool.
That would be wonderful. Yeah, it may not work for us. However, the concept is certainly valid.
Yeah.
And anything to drop down. A lot of like what you saw with Dr. Roberts' presentation, I think it's very helpful there. So this has been great.
Thank you. And just before we wrap up, talking about legacy diagnoses, just a show of hands, and maybe for your institutions as well, who still uses the PSR? This is quite a bit. Are you guys finding the same issue incorporating this and piggybacking it off the PSR? Just open for the floor. Because at our institution, there's still a big drive for the PSR, and I find that comes from a jurisdictional issue with the licensing bodies, where they set the standard or the minimum standard, and everyone sticks to it. So we had to bridge the gap for that, where if they follow the PSR and you get a 3 or 2 3s or 1 4, then kind of like what you were saying, it directs them towards the perio faculty. And once they're directed towards the perio faculty, then we take over. But the problem is the ones that kind of skip under the radar. So going back to the same issue is kind of getting them to join to start looking at things more in more detail. So thank you, Dr. Roberts and Dr. Kano. Appreciate all the information. So we're going to start the workshop section. I'm going to have to ask some people to move around because I'm seeing clusters on the area, and that's going to be a little bit difficult because I actually would like to ask for those who are coming from the same institution to not to sit with each other, to actually spread around the room. So if you look down here, there's 2 tables, table 1. There's 2 tables, 2 over there, 2 table 3s, 2 table 4s, 2 table 5s, and 2 table 6s, 2 table 7s, and 2 table 8s. So if everyone can move around and sit at different tables. The one thing I like to make, though, for table 1, could we please have educators that are from a program without a postdoc program for table 1, and for table 2, educators with a program, with a postdoc program. But all the other tables you can spread around. And just before you do, what I'd like to let you know what we're doing is each group is assigned with a group leader. So every 2 tables, have one group leader. Your group leader has the questions, the topics that you're going to be discussing. The group leader will take notes, and then we're going to give about 45 minutes to the discussion to cover those topics. Then the group leader is going to come back up here and present the group's findings for everyone in the room. So if you can go ahead, and if you have any questions, just raise your hand. Once you're set up, I'll come to the table to help out. Thank you. For the sake of time, if your group comments match something that was discussed by an earlier group, just allude to it and share the newer aspect. So if we could have group one. I forgot all my paperwork here. So.
Hi, I'm Andy Brower. So our group was implementation in the clinical curriculum, programs without postdocs. I want to thank Satish Kumar from AT Still, Dan Tennell from Utah, Dave Paquette from University of East Carolina, Rima Kabir from Montreal, Renee Voyer from Montreal, Samar Shaikh from University of New England, Ravipam Norman, who was faculty for hygienist program in Cypress, California, and Chris Richardson, AAP treasurer, who sat in as well. And so the questions were, what is our experience? When is it being implemented? And then recommendations for best practice. So I'd like to just summarize very quickly. First of all, even though these programs don't have a postdoc, there are wide range of how the programs embrace perio. Some of them actually have a department, and some of them have nothing, okay? And some may have 4 or 5 faculty, maybe 2 or 3 full-timers, and some may have maybe 1. So wide range. One big area of challenge has been schools that use an outreach site and getting the providers at the outreach site on board, okay? So it's hard enough with the GPs who are in the schools to get it, but on the outreach sites it's even harder, okay? There's a wide variation of when is it being implemented. So some have implemented it full bore for the classes that are graduating in 2020, and then obviously all the way down. And some of them are going to start full bore with the class of 2020, I think it's going to be 2024, the incoming D1 class in September, okay? Most of the periodontists from the schools are on board, okay? Still having difficulty, or they're going to carry their card, their cheat sheet with them. One of the comments, which was very telling, is the students understand that we're all learning this together, so they kind of appreciate it, okay? So the biggest challenge in implementing most of the programs, if they have a department, that's good, and they will implement it. Maybe they'll have a timing issue when they can actually lecture, because the schools usually don't have a Perio 101 and a Perio 102, but it's integrated with other courses, okay? But their respective deans listen and say, okay, this is what we got to do. And there are some programs which totally driven by either the preclinic dean or the clinic dean, and there's no control over what the actual content is, okay? So there's a lot of challenges. What are the best practices going to be? Well, a couple of things. First of all, we have to buy into it, because if we don't buy into it, and we got to think this is the best thing since sliced milk. Is there such a thing? sliced bread, that the GPs won't. Okay? So they need to see value in it. The other thing that's going to drive compliance is that the INBDE and the MBDE2 are going to utilize the new classification starting with the class of 2021. So the ones that are graduating this spring will still have the old exam, and the ones graduating next year will have only new classifications. So that's going to drive some accountability. For our hygiene program, kind of a cool thing, they're on board. And what they see when the hygienists are getting out is they actually have some influence as to what happens in the GP program or in the GP offices that they work in. So they are actually ambassadors for what's supposed to happen, okay? That's a very cool thing. And the other thing, the last is let's persevere, because in 5 years, we'll think this was difficult, but we made it, okay? Thank you.
Thank you, Group 1. Group 2, their question was implementation in the clinical curriculum for programs with a postdoc program.
Hello, everyone. Good morning. Thank you for joining. So we had schools representing from all over the place, all over the country. We had Maryland, we had UMKC, VCU, Harvard, South Carolina, and Houston. So more or less everyone agreed that the easiest thing to do is to implement in our postgraduate programs. Done already. On top of what Dr. Brewer related, with regards to the predoctoral programs, it's been rolled over or rolled in as we go. Some schools start in the D1 year and implement on the D2, D3, D4 at the same time. There have been some issues and pushback on implementing in the clinic because of all the gray zones that we have when we're evaluating cases. Not everything is cut and dry. Issues that we've all focused with or dealt with had to do with Axiom, creating new forms and IT support, transitioning to different electronic health records from Axiom to Epic, because that's going to create an extra element of difficulty. And then with regards to best practices, we feel that having our residents being the champions of the new classification system is the best way to go, because they do teach and they do interact with our predoctoral students. We can utilize different flowcharts and modify the flowcharts provided to us by our academy. We're creating forms with regards to risk assessment, because that's one of the newer changes with the current classification system. And there are apps that are going to be coming up. University of Houston, University of Texas, Houston, I'm sorry, has come up with a very easy ABC type of application that they'll be more than happy to share with you. So, thank you.
Thank you. Just a quick question to Group 1, considering what Group 2 was mentioning, using the residents to champion it. Did you guys have a consensus of using maybe hygienist or someone in particular, or do you find it's still the periodontists really championing this in your education institutions? Hygienists helping a lot? Okay. Okay, very good, very good. So Group 3, their question was implementation in the didactic curriculum.
Hi, I'm Georgia Johnson, and this is our table here. We had representatives from across the country, Virginia, California, Missouri, Michigan, Iowa, and Oregon, and represented a diverse, most of the programs had pre and postdoc program, but one program just had a predoc program. And our question dealt with how and when did you integrate the new classification didactically for D1 through D4? And some of the programs didn't kind of wrote off the D4 year, but everybody now is on board teaching the new classification, D1 through D4, as of this year. And integrated through a combination of a lecture, some lecture with video showing cases at the same time, some online tutorials such as we saw this morning. And another means was small group discussions with the students using case-based discussions. And it seemed like that was particularly helpful in terms of the discussion that followed with that. In terms of, the next question was experiences with this, and most of the people felt like the students actually took to this easier than some of the faculty. But special challenges unique to the system were use of the terms localized and generalized, and how we're using that in terms of if that was intended to be applied to the case or to the stage. So I think there's been some confusion on that in the implementation. Another challenge is felt was proper representation of what we previously termed the aggressive periodontitis patient. And then the third challenge is the bone level assessment. It's measuring from, percent root from CJ versus percent normal bone level, which is 1 to 2 millimeters from the CJ. So there's been some confusion on that, especially with that, 15, that first category, the 15%. And then third thing, recommendations for best practices. One was to, perhaps we could share Axiom forms or the forms that we're using to gain some insights in terms of the clinical implementation. And then finally to call Ken Corman and ask him to come and lecture at your program. Several of the people at the table had him come, and he is doing this. He'd probably kill me for saying this, but he's done this, and we found it particularly helpful in terms of helping to clarify in terms of the interpretation.
Okay,
Thank
perfect.
you.
Well, thank you. Thank you, Group 3. So that's a good segue for Group 4, talking about documentation of the classification with the electronic dental records.
Hi, my name is Sarah Bemanesh from McGill University in Montreal. So our topic was about the documentation, electronic documentation, and how it got implemented. My understanding was that most of the institutions in US, they use Axiom. And in some schools, they are still not using Axiom in its full capacity, not forget about the new classification in general. For a lot of forms, they fill it out in paper and then they scan it and add it as an attached document to Axiom, which they need to work on their IT department to implement it to become more actual real electronic recording. And Dr. Iacono actually provided the best feedback as far as how they implemented it at their school. And they had a meeting with their perio faculty first to calibrate everyone on it. And when everyone was in agreement and the calibration was finalized, they had another meeting with their IT department to go over the different boxes or the drop-down menus they need to add. And they added the insurance codes next to the diagnosis as well to make it easier for everyone. So that was the way they implemented it. And one solution that was proposed was that if the institution is using Axiom, they can contact probably Axiom and have them implement the same thing that, for example, institution A is using. I think if you're using Axiom, it's going to be very easy. You can give them an example and say, we want to implement the same system that the other institution already implemented. And maybe you can tweak it yourself. But that needs collaboration between your department and the IT department in school. That's it. Any questions?
That was it. Perfect. Thank you, Group 4. On that point, I think Penelope mentioned earlier, I was speaking with Dr. Nikola Angelov from University of Texas. They're actually developing an app that it's work in progress, which the students and the faculty can download on their phone, and it literally walks them through the steps, asks the question, yes or no, and it basically it's a digital algorithm, and they provide some sort of a code system. So, and they're open for sharing that idea as well. So I think this is a great opportunity for collaboration between different institutions at different levels. So thank you to both of you guys for that. So next group is group 5, and they were tasked with the question, dissemination of the classification to non-perio faculty.
Yes, I'm Binnaz Zirvikioğlu from Ohio State University. So this is a summary from 2 tables, actually. We had several doctors from all over the place. Deborah Foyce, Texas A&M, Elham Alklarkli, University of Minnesota, Sylvia Todescan, University of Manitoba, Canada, Tobias Boehm, Western University of Health, Dennis Martin, Meharry Medical College. Swati Rawal helped me with the second table. She is from University of Marquette. Ying Pan, Midwestern. Sarah Whitener, Southern Illinois. Gary Zweig, Maryland. Diane Dobert, University of Washington. And Dr. Clayman from Ohio State University. So how can we champion this at each of our institutions? So there are several comments, generally complaining about this really depends, and it makes a big difference on local school culture. So one of my colleagues said, perio is the unwanted child from the beginning, and this new classification is another block, and everybody sees that way. And then other colleagues said that general dentists do not care about perio. Either they refer everything and they don't want to do anything, they don't want to take any responsibility, or they want to do everything and they don't listen, they don't consult. And then several of us, actually all of us, apparently teaching multiple versions of the classification now. And there are several reasons for that. We are concerned about national exams and where we are as far as amplifying this at the exam level. We need a fast screening tool, and the PSR is the only one. And incorporating with this is a challenge based on, like, on the floor, clinical teaching wise. So we still need a really fast tool to determine gingivitis versus periodontitis, and we are challenged to use this on the floor still. So one recommendation was how we catch the audience is probably new CODA, ADEA accreditation standards requiring competency level evidence-based dentistry, and us pushing this new classification. Well, the old one is not really evidence-based anymore, and we have this new classification really evidence-based, and we want to apply this, and we should do that based on the science and literature beyond of what we do. So it may be a good catch at the school level, at the administrative level. The second component was who can do this. That also depends on the school. Schools with hygiene program and schools without hygiene program apparently make a difference. Schools that have hygiene programs, actually, they are kind of pushing old established perio folks to move ahead with their own requirements in their educations. So it may be a good idea to have a nice, strong perio-hygiene collaboration against general dentists, because they are kind of against it, and then push it on. We are the experts on this, and this has to go. Type of approach can be a way. And then several of us doing calibrations through continuing education, several of us choosing boot camp type of like 1 week, 10 days, whole school continuing educations. Several of us are killing ourselves, among the, like, we are busy with our requirements and, we have other duties to do it, but we spend a lot of time. And we have the capacity to do it, but providing time and support to go that and train everybody is problematic, but it sounds like perio and hygiene are the leaders in this. And targeted audience, it sounds like general dentists. We have to, catch their attention. And it sounds like several of us are teaching this at D4 level because they are out of the door and they will start practicing as a general dentist. And AGD programs are important to reach out. And so not only D1s, D2s, D3s, but graduating class is important in this matter because they are just this year's general dentists, so it may be a nice idea. With that, everybody thinks that academia should help us providing online materials to use, like case-based, computer-based training tools to use in our calibrations, continuing educations, and Axiom drop-up option, that thing that presented today was very, positive among us. So that's a short summary. I have more to type. Thank you.
Perfect. Thank you. I think Group 5 was one of the larger groups, so thank you for that. So Group 6, they were tasked with treatment planning periodontal cases utilizing the classification.
Okay, so.
Oh, you got a mic up there. Okay.
Is it on? Yeah.
Yes.
So Group 6 had representation of 2 countries. We have the large Canadian contingent, and we had the U.S., mostly Southeast, little Midwest, nothing past Colorado to the west. One of the things I wanted to note here is that I sense a different sense of energy towards the classification all around the room. If we go back to last year, when there was confusion and what are we going to do, I think we have embraced the classification. And if you look at what we've done with implementation, each school is working on their best opportunities to implement and to train their dentists. So we were tasked to talk about treatment planning, but our discussion focused mostly on who is there at the table to recognize and facilitate the diagnosis. Where does that happen? And it ranged from a periodontist, the board-certified periodontist checks every patient and confirms the diagnosis, to when periodontal disease is recognized, the treatment planning now is left up to the periodontist. We feel that classification is important in treatment planning early on. Let me go back to the diagnosis. We also feel that it's great if our graduating dental students know the difference between gingivitis and periodontitis. And if they do that, we're far along. If we then start to look at treatment planning, so when should the periodontist be at the table for treatment planning? Some schools said if the stage is 1 or 2, maybe the general dentistry faculty could do so. But once the diagnosis is 3 or 4, a periodontist needs to be part of that initial treatment planning phase. We had a discussion about who should do that treatment, and there were philosophical differences. Should the stage 3 and 4 periodontitis cases immediately be referred, or should they be treated by a dental student first and then at the phase 1 eval be referred? We can argue about it most ways. There's an argument about the level of experience a student may get from treating one of those more advanced cases versus we're going to have to redo the root planning anyway. Why do we let them do it first? But in the end, it is important that periodontists are involved in the treatment planning of those cases, and preferably as a best practice as early on in the process. When we deal with general dentistry faculty, the calibration becomes an issue, and I think other groups have addressed that as well. We didn't really talk about good models for that, but whatever model, it will be cumbersome and it will be difficult. The other thing is that the classification does bring an opportunity to get people at the table to talk about periodontal disease. So all of us will have to come back to our faculty and talk about this classification, and it's really an opportunity to re-energize your faculty at large at the school about periodontitis and diagnosing periodontal disease. Thank you.
Thank you. The next group is Group 7. They were tasked with the question, communication about care with students and non-perio faculty.
I was group leader at the last minute. So we had really an interesting group that had a variety of experiences because we had some discipline-based faculty and some that were in the comprehensive care or general practice model. And the key communication was having the students understand that periodontal disease diagnosis is important, not just for credit, but for the actual learning diagnosis and critical thinking about periodontal disease. And we found that all of us experienced similar problems with looking at axiom and the periodontal charting and doing a real comprehensive exam. And so looking at attachment loss, where the location of the gingival margin. And so sometimes when we're in a group that there's one periodontal faculty with a large number of students, even though we're allowing the non-perio faculty to check, sometimes you get bogged down on the minutia. And so a lot of the faculty said they were looking, again, someone else had mentioned it, gingivitis, periodontitis, so that they're able to notice, to recognize that difference. So we sort of gave ourselves a little bit of a leeway on that. Let me see what else. Diagnosis. The discipline-based versus the comprehensive care, also, most of us felt that maybe the comprehensive care model isn't really as comprehensive care as we would like, because some of them found that even in that model, they would have a periodontal therapy bay. So there would be 10 or 12 chairs that would be separate, which really is still having that discipline-based model. Other schools would have one periodontist that would cover the whole model. So when we're looking at how is this experience presented, as far as the D1 and the D2s, we felt that it started right away, and the students in didactic, and now with more case-based questions so that it can lead them into preparation for the boards. And then for the D3s and D4s, we're continuing with case-based and surgical experience, that kind of thing. The biggest thing as far as doing the non-perio faculty is calibration. And it was mentioned before, calibration with the outreach programs and things. So we were discussing having lectures that they would attend as well for all the faculty, even in the school, and then having online programs. And in looking at some of the meetings like we had today, if we had something online, there's no interaction, but when you're watching, talking, everybody's like, oh yes, because our group had some very lively discussion because you kind of got excited with the same challenges that everyone had. Another thing, a suggestion as far as the recommendations besides ongoing calibration was maybe to consider having faculty, if possible, that they attend some of the perio classes, the D1, D2, so they can see, like we're doing that with the restorative, just having them see so that more of the faculty that are the clinical faculty are aware of what's being taught in the classes. Oh, and the other thing, a couple of the faculty talked about schools that were moving towards integrated systems, and so incorporating perio into dental anatomy and histology. We don't want to dilute the periodontal training for the patient, for the students. That's it. That was about it.
Perfect. Thank you very much. Group 7. And our final group, Group 8, they were tasked with the question, optimize patient care using the new classification system to focus on prevention, treatment, and referral.
All right, thank you. I represent Table 8. We had a diverse group of hygienists and periodontists on both tables from across the nation and beyond. We have, I think, somebody from Ireland representing dental school from Ireland. The way we understood, I would like to thank you all for your contribution to the discussion. What we understood the topic to be was more how did the new classification change the discussion that we have with our patients. So we kind of framed it in that way with different the subpoints you mentioned. And we concluded that in general, the discussion with our patients has not dramatically changed in terms of presenting the disease severity to them or their treatment options. It may better highlight the patient susceptibility and the implication of the lack of a timely intervention or care for them. It presents a more consistency in the message, and also it presents that aspect of personalized medicine. Now, when the new classification came out, the cancer analogy was given in staging and grading. We had a little discussion on that, about that on the table. And as our group, we advise against that analogy with patients because it could freak out a lot of them when you tell them it's like cancer in stages and grades. There's something to be said about the difference in approaching patients, whether they're in the pre-doc clinic versus the post-doc clinic. If they're in the pre-doc clinic, they don't know yet that they have any form of periodontal disease, gingivitis or periodontitis. When they make it to a graduate clinic, then they already know that, and they're seeking advanced care at that point. So that discussion about their disease may be different at those different levels. Now, it may not change the conversation with the patients, the new classification, but it does allow for better conversation, we thought, with the dental students, with the dentists that are non-periodontists, and with the hygienists, so that they look for risk factors in their patients, thus optimizing their patient care. Because that new classification, as we saw with the presentations, and we've all been kind of using it, it has a framework with built-in factors that are namely the systemic risk factors and the smoking, diabetes especially, and the tooth loss due to periodontitis. And that also seems to affect the perception of the students about how they understand the disease and how they can explain it to their patient. Also including understanding the rehabilitation concept and the need for advanced care beyond periodontal care when they're in stage 3 or 4. So those were somewhat missing with the old system in a way, and because they're in a framework, it forces a discussion, if you will, with this new classification. When we talked about the informed consent, no one has changed their informed consent to reflect anything from the new classification, and it doesn't look like anyone has plans to do so. I will highlight a couple of things that are unique to some institutions. I think, Omid, you mentioned the UT Houston app. We had a representative from UT Houston, and they are using a scorecard printout using the Tonetti Spider periodontal risk assessment, a modified risk assessment of that nature that incorporates their disease classification using the new system, but also their smoking status and their systemic factors. In San Antonio, they asked their pre-doc students to develop a brochure guide or a guide with creative ideas or photos that they can have projects to present, and they're scored on that, and they're scored on their creativity. Now, that doesn't make it to the patients, but they're encouraged to use those when they're going on in their practice. And I don't think they've included the new classification system with that model yet. And lastly, also unique to a different institution, that's where I am at the University of Alabama at Birmingham. We have a wellness clinic. Patients that come to that wellness clinic not only get their teeth cleaned, but they get basically a diabetes risk assessment, obesity, a sleep apnea risk assessment, and of course hypertension, smoking, etc. And they get a scorecard at the end of their visit to see where they are and proper referrals when needed. We have not incorporated the new classification system, the Perio system, in that scorecard yet. And that's all I have.
Great, thank you very much, Group 8. So there was a couple of points I wanted to kind of shed some light on based on the discussions. And I agree with what Nico was mentioning earlier, which is a difficult thing for us as periodontists to capture and grasp, but it's really important for us to get our minds around. We're like the experts of minutia. We care if a literature has 0.2 millimeters of clinical attachment gain, and what we look for is a star to see if it was statistically significant or not. That's just who we are. That's fine. But we need to take a big step back and look at the big picture of things here. I think the common issue we're all facing with, and I don't mean just us in this room, but all of us as our profession, is just bringing awareness. The moment the discussion is being had with a fellow dental professional colleague, be it a hygienist, a general dentist, or another specialist, that's victory by itself. Because the fact that they're approaching you to discuss it, that means a check mark has gone off in their treatment algorithm and they're saying, wait a minute, let me think about perio. And the rest is pretty much what we do. So one thing which we should not be discouraged is all these hurdles that we face, but rather look at each one of them as an opportunity to engage that individual, to engage that department, that leadership position, whoever it is that's creating those in your educational institutions. Because one of the things that I've approached this personally at our institution, and I kind of borrowed the idea from the ITI where they look at implantology and they subcategorize it into straightforward, advanced, and complex. What I tell all the students, and when we've done these calibration exercises with our general dentist faculty, and even outside us in terms of CE for the dental community, I tell them the way you need to look at this is every patient that comes to you has to be classified into 3 categories. Are they a straightforward case? Are they an advanced case or a complex case? The idea is you should be equipped in your office to handle the straightforward case between you and your hygienist. The complex case is easy. Send it to the specialist. That's just a waste of time and headache. That's either loss of money, potentially, or loss of time from your family, because you don't want to deal with that headache. And they capture that idea. The advanced cases are the difficult ones, which really comes down to the competence of that individual. And the example I give them as a periodontist, if I had to tweak around a little filling while I'm doing surgery, to me that's a straightforward thing. Polish some margins or do something. But if I got to deal with a full mouth restorative rehabilitation, that's straightforward, complex. That goes to the prosthodontist. But when you got those little in-between things, it might be a single crown or a 3-unit bridge. To me, to my competence, that's considered advanced. I'm not touching it. But if the restorative dentist does 3-unit bridges every day in their office, it's still considered advanced, but for their competence, they can handle it. So I kind of try to take a bigger picture and make it more comfortable for them. And one of the things I found that helped with us was the question, why do we have a classification? I know we get caught up in the details as periodontists and the justification, but the simplest way, I guess, to bring it about is it's a common language of communication. Because when you really think about it, that's the one thing we're missing a bit in dentistry compared to our medical colleagues. Because if someone has a specific type of cancer staged and graded at a specific rate, that common language holds true, be it in the US, be it in China, be it in France, or wherever it is. But when we come to the language of periodontics or dentistry, we start explaining things, and it's a paragraph long with bleeding here, probing there, and attachment loss and radiograph, whereas this gives that common language. So if you tell your patient, Mrs. Smith, you have stage 3 grade B periodontitis, that diagnosis, that language should hold true if you're in California, if you're in Canada, if you're in Chicago, or if you're in England, because it's the same language for communication. And that's the step taking back and not getting boggled with the minutia. Now, having said that, once they're within our web of periodontics, then of course we can take care of the rest. And comparing this meeting to last year's meeting, I think it's a big success for periodontics over this past year, because as it was mentioned earlier, last year there was a lot of anxiety in that room when we were all exposed to the different ideas and the concepts. But I actually want to congratulate each and every one of you for everything you guys have done for the profession in your institutions, outside of your institutions, in the community. Because at the end of the game, I believe our second role, our first role being care to the patient, our second role is to bring awareness to our profession, by the extension of which we're upping the standards of care for our patients. So with that note, I want to thank each and every one of you for coming down today. I want to thank our group leaders, and I want to thank our academy staff for all their help, without which this would not have been possible. And thank you again, and hopefully enjoy the rest of the meeting.